like PFO, other mechanisms, things like PFO or patent forming a valve. Someone has DVT and then all of a sudden they have a clot that went to the brain. Usually if it's a DVT coming from the peripheral, it has to go through the right atrium to the right ventricle, and if it escapes, usually there's a, and goes to the body, it usually means that there is a hole that's actually that patent forming a valley that can actually cause it to cross over. Okay, fibromuscular dysplasia, aortic artery dissection. They can have sickle cell anemia that can have this misshapen syndrome, the vasculitis that can actually cause a inflammation of the vessels that can cause the vessels to clamp down and cause strokes in that way. Okay. Symptoms: anterior circulation. Anterior circulation, any area in the anterior circulation can cause it. Remember, the anterior circulation is the two cerebral hemispheres. Remember that circle of Willis we talked about, the MCA, the ACA, the ACOM, or the PCOM, that's all anterior circulation. The vertebral arteries, the basilar arteries, and the posterior cerebral artery, those are all posterior circulation, feeding the cerebellum and the brainstem. Okay? So contralateral weakness, again, arm, face, sensory, they can have aphasia. Remember, your speech centers are in the anterior aspect, the cerebral hemispheres. Posterior circulation, you can actually have a posterior cerebral artery stroke that actually, because the part of the posterior artery can feed parts of the occipital lobe, so you can actually have a henomatous hemianopsia, double vision from the brainstem, vertigo from the brainstem. Okay, dysarthria, motor weakness, brainstem, again, facial muscle weakness will give you dysarthria. Dysphagia, difficulty swallowing, brainstem, cranial nerve deficit, incoordination because of the cerebella, gait dysfunction in cerebella, loss of consciousness, brainstem injury will give you that. So what a stroke looks like on CT, this dark area here is the area that doesn't have the perfusion. This area here is that clot in the vessel. And this is right here, if you remember, the middle cerebral artery coming off the ICA. So you have the middle cerebral artery going out here, and this is a middle cerebral artery clot here on the CT. That's just for information purposes. So management of stroke. Rapid identification of stroke is important. EMS transfer, and get them to the hospital, get them to a stroke center. Remember, in the past we used to just leave stroke patients to sit there. Now we do not do that anymore. We need to get them to the hospital between the 3 and 4.5 hour mark. Now standardized stroke centers are standardizing that 4.5 hour mark. It's not yet FDA approved, however, that's the standard of care now. Mechanical thrombectomy for patients with large vessel occlusion is the standard of care. Inclusion criteria for TPA, alteplase, that we're using now for patients who come in with signs and symptoms of a stroke, with an NIH score that is, I don't think I included the NIH scale in here, which I should have, so take a look at that. Usually you start initiating TPA for a patient with an NIH score greater than 4, and you can go all the way up. Patients with really large, devastating stroke will have an NIH greater than 21, and the neurologist can decide at that time if they think getting the patient TPA is appropriate, because usually those patients, the studies have shown that they can actually have higher risk for bleeding. But anyone with an NIH score between 4 and let's say 20 is fair game for getting the TPA if they're getting with that 4.5 hour period. Things that will cause them not to get TPA. Remember, it is a thrombolytic, so it's going to break up clots. So if a person has a propensity to bleed, you do not want to give it to them. If a person has a stroke, any type of intracranial hemorrhage, you don't want to give it to them. If they had a history of a subarachnoid hemorrhage, no. If they're actively bleeding, no, you're not going to give it to them. The same things that you're going to think about when you're giving the alteplase to a patient with a MI. The same thing goes here. If they have bleeding tendencies, you don't want to give it to them, okay? Current severe uncontrolled hypertension. The threshold here is 185, okay, for 110. If you've had a patient come in with a blood pressure of 200 over 120 and they're supposed to get TPA, you want to bring that down to less than 185 over 110. 185 systolic, 110 diastolic, you want to bring it lower than that. If you're giving them medications to bring it down and they're not able to bring that blood pressure down, you cannot give them that TPA. But if you give them the medications to bring the blood pressure down and it does come down, you can give them that TPA. Okay? GI malignancy with, or GI bleeding with the last 21 days. Coagulopathy, if they have an INR greater than 1.7, if they're taking factor 10 inhibitors, or if they're taking thrombin inhibitors, you do not want to give them that. Okay, if they've used glycoprotein 2A or 2B inhibitors, this is a iffy kind of one. I think that sometimes neurologists can make a decision if they still want to give the patient that. Infective endocarditis, they can actually bleed, if you give them TPA with infective endocarditis. Aortic dissection, that would be a nasty, really, really bad mess if you give them TPA. So here you see the characteristics and patterns and the things that were contraindicated. The person has to be greater than 18. These are the indications, I should say, for alteplase or TPA. The doses, usually 0.9 milligrams per kilograms. You can only give a maximum of 90. You will give over a 60-minute period, with the first 10% given in the first hour and the rest given over the next time. Okay. The first 10, not 60 minutes, but the first 10% given over 1 minute, so it's a bolus, and the rest given over that 60-minute period. Okay. How do you judge stroke recovery? They use this modified Rankin scale to tell how well that person is doing. They look at them post-procedure, post-thrombectomy or post-TPA. And a modified ranking of 1 to 2 is where you really want that patient to be. Slight disability or no disability at all. A modified ranking of 3, moderate disability. Well, if they came in at a modified ranking of 5 and you got them to 3, that's good. But you want it ideally between 1 and 2. 3 for the most, but moderately severe disability is not where you want them to be, or 5, or 6, they're dead. Hemorrhagic strokes. Different types of hemorrhagic stroke. You have intracerebral hemorrhage, which is bleeding into the brain parenchyma, and then you have subarachnoid hemorrhage, which is bleeding into the subarachnoid space. What causes intracerebral hemorrhages? Things like hypertension due to rupture of a vessel. You can have bleeding tumors that can give you intracerebral hemorrhages. Okay, so rupture of a blood vessel. You can also have intracerebral hemorrhages due to things like arteriovenous malformation, where you have a abnormal joining of veins and arteries that can give you that that arteriovenous malformation that can rupture and cause an intracerebral hemorrhage. Okay. This is what it looks like. Remember, on CT the ischemic area was black, and on CT the hemorrhage or the hemorrhagic area is white. Okay, this is an intracerebral hemorrhage. These are the cerebral hemispheres. This is the blood in the cerebral hemispheres. It's not out here. It's actually in the brain parenchyma itself. That's an intracerebral hemorrhage. Okay. We have the ICH score scale, and this is actually based on a lot of research that they've done over the past few years, and you actually score them coming in. And it tells you a 30-day mortality or a guesstimation of a 30-day mortality if they come in with a certain number. Okay, you don't have to memorize this, it's more for informational. But usually the patients with infratentorial usually do less, supratentorial, remember, it's above the tentorium, in the cerebral hemispheres, above the cerebella and the brainstem. Infratentorial is below the cerebella and the brainstem. Okay? If it goes into the ventricular system, it can cause more backup, or it can cause difficulty with circulation of CSF, and can cause issues that way. Subarachnoid hemorrhage. What can cause subarachnoid hemorrhage? Aneurysmal rupture. Remember your aneurysms, we talked about it earlier, form at the bifurcation of vessels, so you can see them here. You can also get subarachnoid hemorrhage from an anterior venous malformation. Okay. What usually causes these aneurysms? It can be prolonged hypertension. Things like nicotine can weaken your vessels and put you at high risk for brain aneurysms, so you want to look at that. If the person is a smoker, they're at higher risk. Usually these patients come in with a really bad headache, and it can be the worst headache of their life, and it doesn't necessarily have to be the worst headache of their life, but they can actually have these bleeds. This is what the subarachnoid hemorrhage looks like. If you look at it, you see, and this is where the vessel ruptured, but you see it's not in the brain parenchyma itself. The blood is like almost like distributed, like flattened over in the subarachnoid space. Okay, so what usually happens? Sudden onset headache, meningeal signs or meningismus, nuchal rigidity, that's where your stiff neck is, photophobia, inability to tolerate light. They'll come in, nausea, vomiting, transient loss of consciousness can happen. Again, it does not need to be the worst headache of their life. It can be, but it does not necessarily have to be. I just had a patient with a subarachnoid hemorrhage, and I asked him, is it the worst headache of your life? And he was like, not really, but he did have a subarachnoid hemorrhage, so it doesn't have to be the worst headache of their life. The Hunt-Hess scale is what we use to grade subarachnoid hemorrhage, hemorrhages. If a patient comes in and they're being treated for an unruptured aneurysm, they come in with headaches, and we're going to talk about that when we do headache differential diagnoses. And they have an unruptured aneurysm, it's a 0. And they have a Hunt-Hess scale of 0. If they come in deep coma, they have a Hunt-Hess scale of 5. 2, moderate to severe headache, no clear neurological deficits except for cranial nerve palsy, it's 2. So 0, unruptured, 5, deep coma, 1, 2, and 3, and 4. You can all, patients who come in with a Hunt-Hess 5 are the ones who usually do very poorly and don't usually leave. Okay? Complications of subarachnoid hemorrhage, they are endless. You can have dysautonomias, you can have patients who have stunned myocardium. You can have vasoconstriction because of blood outside of the vessels can actually cause vasoconstriction and platelet extravasation, which can give you what we call vasospasms. And these patients usually do really poorly because if they get vasospasms, then they can have a stroke on top of their subarachnoid hemorrhage. So vasospasm is one of the big problems that can actually give you severe complications. Stunned myocardium, where they actually have decreased, it's almost like they're going into a severe heart failure, and decreased cardiac function. It usually comes back, but for that time it can give you that, that stunned myocardium associated with the subarachnoid hemorrhage. Risk factors, remember we are modifiable versus non-modifiable. They're the same for intracerebral hemorrhage versus ischemic strokes. Hypertension, smoking, all these, hyperlipidemia, diabetes, heart disease, all these are modifiable risk factors. The things you can't change about yourself are the unmodifiable risk factors. Your age, what gender you are, males are more prone to intracerebral hemorrhages, ethnicity, African Americans, Indians, Hispanics, higher risk for hypertension, therefore higher risk for these. Heredity, depends on what your family background is. History of prior stroke or TIA puts you at a higher risk, and you can't change that, so, okay. Signs and symptoms of stroke: weakness on one side of the body, speech disturbance, headaches, sudden loss of consciousness, all these visual changes, facial asymmetry, difficulty swallowing, all these are signs and symptoms of stroke. Differential diagnosis for stroke. Remember, not everything in the brain is going to be considered a stroke. You have subdural hematomas, epidural hematomas, those are traumatic in nature. And so they can look the same though. Anything that compresses the brain or causes injury to the brain can actually present the same. So if someone comes in with weakness on the right side of their body, and they fell, and they have a subarachnoid hemorrhage, or subdural hemorrhage, that's not a stroke. It's a traumatic injury that caused these symptoms. So they can all look the same. So these things are going to be your differential diagnosis. If someone comes in, altered mental status, weakness on one side of the body, difficulty speaking, you can consider any one of these. Complicated migraines can actually be one of those. Brain tumors, thrombosis in the venous system that helps to drain the brain. Hypoglycemia can actually present looking like a stroke. That's actually one indication for holding TPA. If someone is hypoglycemic when they come in, you actually have to hold TPA until you correct the hypoglycemia. If the patient still has symptoms after you correct the hypoglycemia, then you may pursue go with the TPA. This is actually one thing that you have to test before you give TPA. You must do a blood sugar test. Subdural hematomas, we quickly touched on these when we talked about the meninges, but usually it's ripping or tearing of the bridging cortical veins, and it's in the subdural space. If you look, the blood is outside here. It's not in the brain parenchyma, but it's in the subdural space here. Okay, and this is below. This is the dura mater here, and this is the blood under it. Remember, epidural, the blood will be between the dura and the skull. Subdural, between the dura and the arachnoid layer. Epidural hematoma, if you look at what the subdural hematoma look like, it's almost like this concave kind of appearance. And then you look at the epidural hematoma, it's usually like this convex type of appearance. And then if you look here, we just talked about it, and remember we said the middle meningeal artery is usually what's lacerated in the epidural hematoma. So here you have the middle meningeal artery lacerated, and you have blood, and this is the dura here that's being pushed in, and you have blood between the cranial vault and the dura. Okay, coming down the home stretch. Increased intracranial pressure. What can cause increased intracranial pressure? A lot of things, okay? A space-occupying lesion, any blood swelling in the brain can cause it. The Monroe-Kelly doctrine says that there are only 3 things that should be existing in the brain. That is brain tissue, cerebral spinal fluid, and blood. If any one of those things increases, one has to decrease in order for us to maintain homeostasis. So what do we say one has to decrease or increase? When we have a patient who has a brain tumor, that's a space-occupying lesion. Remember, the skull, the cranial vault is fixed. It does not expand, okay? The chest or the thorax expands. The skull does not expand. So whatever is in there is supposed to be in there. If you have something else, things have to shift over in order to make space. So that's what increased intracranial pressure is. Intracranial hypertension, tumor growth, edema, you have a stroke, a large hemispheric stroke, and the brain starts to swell. That's going to cause increased intracranial pressure. Too much CSF, as in hydrocephalus. Hemorrhage, you have a subarachnoid hemorrhage, you have a intracerebral hemorrhage, that can cause increased intracranial pressure. Okay? We have a system called autoregulation. Autoregulation is where the body tries to adjust to the changes or the shift in brain components to kind of accommodate that new area in the brain that's not supposed to be there. So the shifting of that is like the diameters of the vessels will shrink so you can get less blood in the brain, so you shunt blood out of the brain so you can make space for what's in there. But this is only a temporary measure. It only lasts for a little while. and then you can have herniation of the brain on the brainstem. Because remember, the foramen magnum is the only opening. So what happens is the brain tissue swells, it can't go this way, it's going to come down the foramen magnum, that only opening, and push down on the brainstem. Normal intracranial pressure is 5 to 15. Anything above that is increased intracranial pressure. We talked about this, what the Monroe-Kelly doctrine is. Again, signs of herniation or increased intracranial pressure: headache, nausea, vomiting. The vomit center is in the brainstem. If someone's vomiting, you know that brainstem is being compressed, and you know that patient's at increased risk. 6, nerve paresis, third nerve paresis. Remember, cranial nerves are in the brainstem, so these things will be compressed. Cushing's reflex, hypertension, bradycardia, bradyapnea, okay? Papillary edema, swelling in the pupillary area, the optic disc swelling, all this swelling in the eyes will give you, it can be a sign of increased intracranial pressure. You see this a lot with patients who have pseudotumor cerebri. Papillary edema would indicate, and then you do an opening pressure where you do a lumbar puncture and let see what the pressure comes out at, and it comes out elevated because they have a pseudotumor cerebri. Okay. Development of signs of herniation: fixed dilated pupil, contralateral hemiparesis, posturing. Remember we talked about extensor posturing and flexor posturing, and these can actually indicate it. Cushing's triad. Okay, you see it with increased intracranial pressure. They usually have increased blood pressure, low pulse, and low respirations. They're not breathing, heart's not beating, and the blood pressure is driving up. That means that your fight or flight is in full gear, trying to get us to get blood pressure to the brain. Okay, that's why the systolic blood pressure is up. Heart rate, the heart is like poofed. Oh my God. It's working so hard to try to get the blood pressure up that it gets tired. All of a sudden it's not beating anymore. Decreased respirations. Okay? All right. Other neurological diseases. Okay? These are things that you're going to see that can cause changes in mental status, changes in gait, changes in muscle strength or motor. And these we're going to talk about a little bit about Parkinson's disease. This is a really great picture because it has everything. It has the triad, bradykinesia, tremors, and muscle rigidity. It's associated with Parkinson's disease. Mass facies to posture, pill rolling. Remember, tremor at rest is usually Parkinson's. Tremor with movement is usually physiologic. Tremor at rest is usually pathologic and associated with Parkinson's disease. Pill rolling is what you see. They usually have rigidity, so you're going to do cogwheeling, and you see you can take their hand and try to move it, and you'll feel it like almost like a hinge that's like stuck. You'll feel it. Mental status deterioration. A lot of these get Parkinson's patients in their advanced stages get dementia, depression. Usually they have poor postural, they have postural instability. If I'm standing here and you come behind me and you pull me backwards, I may take a step and I should be able to hold myself. With a Parkinson's patient, you pull them backward and they take multiple steps, or they even may fall to the ground, and that's the postural instability. That's what we have right here, okay? Autonomic dysfunction associated with Parkinson's. They got a lot of hypotension, constipation, diaphoresis, difficulty in urinary difficulty, sexual dysfunction, and that's all due to the autonomic nervous system getting the dysfunction associated with the Parkinson's disease. Olfactory dysfunction, they usually have difficulty identifying or discriminating in different odors. This is another indication to check in cranial nerve 1. Okay. diagnosing or Parkinson's disease, they have to have 2 of the 4 principal symptoms. They cannot just have one. They usually have to have at least 2 of them in order for you to diagnose them. Huntington's disease, also known as chorea. This is a autosomal dominant disease. And this is severe, I forgot to mention this, Parkinson's disease is implicated in the basal ganglia. It's usually a lack of dopamine in the basal ganglia that actually is causing a lack of inhibition of acetylcholine. Acetylcholine at the neuromuscular junction causes muscle movement, but dopamine is needed to all dampen it. If you don't have dopamine, then you have continuous movement due to acetylcholine secretion. So Parkinson's disease is implicated in the basal ganglia, lack of dopamine. Okay, Huntington's disease also implicated in the basal ganglia. Okay, severe degeneration of the basal ganglia, the caudate nutrient and putamen are usually what? And this is depletion of GABA. GABA is a neurotransmitter. It's actually a inhibitory neurotransmitter, so it kind of slows things down. Things that you give for seizures and all that are GABA inducers, so it kind of slow things down. We talked about that in pharmacology. Okay. Chloroform movements are what we have with Huntington's disease. So it's just like dance-like rhythmic type movements that you see associated with that. Okay, disrupted in thought process is associated with it. Alzheimer's disease is the most common form of dementia today. They don't have real concrete evidence what causes Alzheimer's disease. Still, they're linking the neurofibrinic tangles that are in the brain that may cause it. Diagnosing Alzheimer's and dementia is very time-consuming. It should not be taken lightly, I should say. Not time-consuming. It should not be taken lightly. You have to do a battery of tests in order to diagnose someone with this. Because remember, this is something that's life-changing, and there's no cure for it. Okay, you can actually decrease the symptoms, but there's no cure. Okay, just like Parkinson's, there's no cure. 4 A's that are associated with it: amnesia, aphasia, apraxia, and agnosia. Amnesia, difficulty remembering; aphasia, difficulty with speaking; apraxia, difficulty performing familiar acts; and agnosia, difficulty, it could be visual or sensory, you can identifying objects. Again, this is a neuritic plaques or the neurofibrillary plaques or senile amyloid plaques. That these are a lot of the hypotheses that are associated with the possible causes of or pathophysiology for Parkinson's disease. All right, we're almost there. Hang in there with me for a little while longer. Hydrocephalus. Hydrocephalus. Remember we talked about when we did a neuroanatomy, we talked about the ventricular system, and we said we have 2 lateral ventricles, one on the right, one on the left, and we have the foramen of Monroe that connects the lateral ventricles to the 3rd ventricle, and then we have the aqueduct of Sylvius that connects the 3rd ventricle to the 4th ventricle, and then we have foramen of Luschka, foramen of Magendie that takes CSF out around the brain and the spinal cord. We also said that we have things that we call arachnoid villi that are in the subarachnoid space, and the potential spaces known as the venous sinuses that helps to reabsorb CSF. We said that CSF is made in the brain at 25 mLs per hour every hour, and it has to be reabsorbed at the same amount in order for us to have homeostasis. Okay. Now, what we have a blockage of an area here, or if we have blood going into the ventricular system, then we won't have CSF. The choroid plexuses are in the ventricular system, and that's what makes CSF. And usually you can have a tumor associated with the choroid plexuses that can give you too much CSF also, but usually not the case. Usually when we have hydrocephalus, it's usually because there's a blockage somewhere, or there is a difficulty with reabsorbing CSF. And then we have the two types of hydrocephalus. We have obstructive versus communicating versus non-communicating hydrocephalus. And we said non-communicating usually means that there's a blockage here somewhere in the ventricular system, and then the communicating is usually because the arachnoid villi are not reabsorbing CSF. Signs and symptoms: irritability and head enlargement in kids. You'll see it. Crackled spots in the head, you can see them here. This indicates increased pressure. Transient illumination, you're seeing a light on the head, especially for kids. Sutured diastasis, where the sutures don't come together well, can be indicated of it. We just explained what the communicating versus non-communicating hydrocephalus is. Normal pressure is another. Normal pressure hydrocephalus is another form of hydrocephalus that's out there. Normal pressure hydrocephalus, there's no blockage, there's no problem with the arachnoid villi. However, this person ends up having enlarged ventricles and not circulating CSF like they should. Usually it's in older people. The pathophysiological process of this is not well explained, but the symptoms can also be mistaken for dementia. These patients, they get confused, they start acting really strange, they don't walk right, and they start urinating on themselves. So the triad of symptoms that neurologists usually look for when they're trying to diagnose normal pressure hydrocephalus is wacky, wobbly, wet. Wacky meaning that they're altered, wobbly, they have difficulty walking, and wet, usually they're incontinence. And someone who comes in who starts deteriorating and have these three findings should have a workup for normal pressure hydrocephalus. And how they work it up is they do a large volume tap. So they'll do a lumbar puncture and take off CSF, and when they take off CSF, they'll look to see if this patient's symptoms improve. If these patients' symptoms improve after high volume tap or high volume lumbar puncture, then they can actually say that it's possibly normal pressure hydrocephalus, and this person will buy themselves a VP shunt where you can divert the flow of CSF. In the communicating and non-communicating, you can also be the same treatment measure. All right, we have two autoimmune conditions that we're going to talk about: multiple sclerosis and myasthenia gravis. And I want you to remember the differences between the two. They're both autoimmune. Multiple sclerosis, demyelinating disease of the central nervous system. The incidence is higher in women than it is in men. You see it a lot. These patients, not the cell body, but the axon. You have demyelination of the axon. And usually what happens is that messages cannot be transmitted properly throughout the spine, or throughout the brain or the spine, wherever. So you see immune mediated, not sure why it happens. They can come in with optic neuritis, they can come in with paresthesias, clumsiness, just because the messages is not getting sent to where it needs to go. Onset 15 to 50 years old. How do you treat it? It's autoimmune. It's immune system attacking itself, so you're going to use